Hey, good morning. It's a bright sunny day from my recording studio here in my car. Had a good swim. It's an off day, but swam a mile, a nice slow mile in about half an hour. Worked on form. But we're here to talk about rheumatoid arthritis. I've had a lot of requests, both local, national, international. I thank you all from the 75 countries of rheumatology students and residents, fellows, other attendings, and anybody else who's interested in learning from me. I've been told I'm arrogant. Maybe I should be, because I think I know this information pretty good. So, anyway, I'm trying to get this thing so that everyone can see me without the sun in my face. I'm clogged up from the chlorine, sorry. Okay, so how do I know I have rheumatoid arthritis? And let's talk a little bit about RA. So, hey doc, my joints hurt, my doctor referred me to you, and my test is positive. All right, well, the first thing, we're going to assume it's a rheumatoid factor, but often it's going to be an ANA or a SED rate. So, does having a polyarthritis, and you can name your joints, does having a polyarthritis and a positive rheumatoid factor mean you have RA? No, of course not. Is there a chance? Yes, of course there is. So I'm going to discuss a little bit about this. If you have an elevated SED rate, it doesn't mean anything. If it's over 100 or over 90, it probably means you've got a source of inflammation. Are there such things as disproportionate SED rate elevations where it's high and you're fine, or it's low and you're sick? Absolutely. Do I follow SED rates in my rheumatoid patients? Never. Why don't I follow them? Because I'm not going to treat a change in the SED rate. I'm going to treat a change in the patient's symptoms. All right, so again, we got to stay focused on RA. We don't have all day on YouTube. So, rheumatoid arthritis is a systemic disease with a predilection for inflammation in the small joints in a symmetric pattern. Okay, again, in English, the knuckles, the wrists, the toes, the ankles, and frankly, it could be the elbows, shoulders, hips, and knees, get inflamed. What is inflamed? Definition: red, tender, warm, swollen. If I missed anything, that's close enough. If you wake up in the morning stiff for an hour, not for 5 minutes, but for an hour, then you're stiff, which means you're inflamed. How can you wake up in the morning and be stiff for an hour if you didn't do anything besides get a good night's sleep? Well, more than likely, if you have RA and it's not controlled, you didn't even get a good night's sleep. But that type of poor sleep would give you stiffness for 15 minutes or less, while rheumatoid stiffness is going to be 35, 45, 55, or in the hours of stiffness. Okay, so not only are you stiff, the stiffness makes you disabled. Who gets RA? Women get it more than men. There's somewhat of a bimodal distribution by age, excluding children. Of course, there are childhood forms of juvenile arthritis that are virtually the same as they are in adulthood. However, there are differences which we can discuss at a juvenile arthritis lecture some other day. For those of you who don't know, I do treat children with juvenile arthritis. There's no reason to be driving around to DuPont, Penn, CHOP, or St. Chris. If I need a second opinion, my go-to guy is Dr. Don Goldsmith, best pediatric rheumatologist in the world, right here at St. Christopher's Hospital in Philadelphia, and he's handy for backup if I ever need it. Okay, back to RA. A typical case is a 40-year-old woman with a 6-month history of generalized swelling and aches that are gradually getting worse, with morning stiffness more than an hour. The condition is a very destructive disease. Untreated, it will cause erosions and destruction of joints, bones, ligaments, tendons, and this is what leads to disability. I mentioned it's a total body disease, so what does it involve? You can get rheumatoid nodules, which are subcutaneous, which means they're under the skin. Those nodules, they are part of active disease. They're a poor prognostic indicator. You can get the same nodules in the lung. Since we mentioned the lung, well, for one, nodules should not be taken for granted. You can be an RA patient with rheumatoid nodules and still get lung cancer, so you have to evaluate any new nodules. Next, in the lung, pleurisy. In the lung, you can have interstitial lung disease, which, if it's caught early, it can be treated aggressively with very strong anti-inflammatory and what we call cytotoxic drugs and high-dose steroids. Please don't think that steroids are your enemy. They're not. Steroids, when used properly, are a mainstay in the treatment long-term of severe disease, and they work very well with, in my opinion, very minimal side effect compared to the the risk-benefit ratio, I believe, and I believe this based on almost 30 years of experience, that small doses of steroids in sick RA patients is far better than not giving them steroids and worried about the few side effects, which frankly you can control. If you get high cholesterol from steroids, you'll take medicine for cholesterol. If your sugar's high, you'll adjust your sugar. If you get cataracts, you'll get them fixed. If you have a problem with your mood, you probably had an attitude problem beforehand, but that can be adjusted as well. So, yes, there's many side effects, but yes, there's many benefits, and the benefits outweigh the risks, and I mean that sincerely. So, moving on, what other parts of the body are involved in rheumatoid arthritis? Well, you can get heart disease in RA, you can get valvular disease, but more commonly you get pericardial disease. Similar to pleural effusions or pleurisy, you can get pericarditis or fluid around the heart. The treatment is not surgery, it's steroids. In the cardiology world, when they have a case of pericarditis and they don't know the cause, they often use colchicine and NSAIDs, and NSAID is something like Motrin. In rheumatoid arthritis or lupus, we use prednisone. We do not use surgery, we do not do pericardial windows. This is reserved for people that are literally about to die from so much fluid squishing their heart, which is called cardiac tamponade. This is not something we see commonly, and frankly, there's been a dozen cases I've seen in 5 years where unnecessary surgery was done when 1 or 2 doses of high-dose IV steroids would have fixed the problem. Next, so we've got nodules we talked about. We mentioned the heart, we mentioned the lungs. We didn't mention the eye. So people with rheumatoid arthritis can get what is called scleritis. It's an inflammation of the sclera. It leads to dry eyes. Can be very debilitating, dry, itchy eyes, trouble reading, pain with vision, and so on. You can get rheumatoid vasculitis. Vasculitis means the blood vessels can become inflamed. Typically, it's a small to medium vessel vasculitis. It is not a large vessel disease. So small vessels, what do? Well, if you have RA with small vessels, the classic prototype is that you get gangrene of your fingers because the vessels going to your fingers are inflamed and clogged up, and there is not enough blood to get to those fingers, and therefore the ends of the fingers die like a heart attack. They become infected. The patients need long-term antibiotics, often surgery, and this is a big problem. This is seen in severe, long-standing disease that is poorly controlled. We see this much less now than when I started my career. When I started my career, we had medicines that were maybe on a scale of 10 being the best and 0 being garbage. We had drugs that were at best 3 or 4/10. Now the drugs are bordering on 9/10. I say only 9 because 10 would be a cure. And while we can completely remit you or very close to it, and we can hide most of your end organ damage, such as all the things I'm mentioning, vasculitis, eyes, lungs, heart, skin nodules, we can do all these things, but we can't cure it. And finally, the kidneys can be involved. Amyloidosis is a protein that collects in chronic disease. Rheumatoid arthritis is a chronic disease. Although with the new treatments, honestly, I don't think we're going to see this much anymore because we've reversed the course of disease with the biologic drugs. So that will lead me to talk a little bit about the treatment. I'm sure I left out a lot. I don't work with slides. I just shoot from the hip. You're going to have to point specific questions at me, and I'll answer them individually, or I can do a lecture on them if there's enough people interested in that same topic. So what's the treatment for rheumatoid arthritis? In the initial stage, you have to do the evaluation. So one, you want to make sure that the rheumatoid factor and the CCP antibody correspond to the arthritis, and that you're not dealing with a patient with hepatitis B, TB, endocarditis, or any number of other diseases that mimic rheumatoid arthritis, whether it be lupus or the other things or many others. This is very common. So now that we've confirmed our diagnosis, what do we do for treatment? Well, we start with an anti-inflammatory drug. We get the inflammation under control quickly, and we use methotrexate virtually 100% of the time. Methotrexate's been the gold standard and the mainstay of treatment somewhere around 50 years. Originally thought to be dangerous, it's not. When I was running a hematology clinic back in the 1980s, we were giving methotrexate into the spinal cord. We were using 500 and 1,000 milligrams at a time. Today we use between 10 and 20 milligrams a week. So I don't think anyone needs to worry about methotrexate side effects. What do I normally hear from patients? 1 in 100 patients has hair thinning. 1 or 2 out of 100 has nausea. Can we work around the nausea? 100% we can. But for that answer, you need to come to my office. Biologic therapy, what am I talking about? All right, biologic drugs. Biologic drugs target what are called pro-inflammatory cytokines. What on earth does that mean to the lay public? Pro-inflammatory means it makes inflammation, and a cytokine is a cell. So there are cells floating around your body that are activated in a specific mechanism between white blood cells called lymphocytes, which are further broken down into B cells and T cells, which cause a chain reaction to activate these pro-inflammatory cytokines. Most of these pro-inflammatory cytokines are involved in stimulating or uploading of what is called TNF, or tumor necrosis factor, or TNF alpha, or tumor necrosis factor alpha. So we have 6 or 7 drugs that can essentially disable these products, thus reducing inflammation. So before I even mention the fact that I'll name a few of the drugs, there's Cimzia, there's Remicade, there's Aria, there's Simponi Aria, there's a bunch of them. People who don't have offices or facilities where they are able to give the IV drugs, which frankly do work better, I think, they're stuck giving the sub-Q Humira or Enbrel. And depending on your patient population, you may not want people injecting these dangerous or potentially dangerous drugs by themselves, because they may not follow the directions or know that you can't give it to yourself when you're sick, and so on. And my staff, we would be the ones to determine if you can or can't get those drugs on a given day. So I want to stay on topic. The biologic drugs are special. So I mentioned TNF. There's interleukin-1, interleukin-6. There's many interleukins. These are also pro-inflammatory cytokines. They can be blocked. By reversing these, we have found that we reverse the course of the disease. Literally turn around the erosions and destruction. I've seen it happen. Others have seen it happen. The patients are in heaven. They literally think I parted the Red Sea after they've been on proper treatment for 6 months after getting treated either incorrectly or misdiagnosed for a lot of time. It's very gratifying to help these people because the changes are remarkable. The most astonishing thing I've ever seen, 10 years ago, a patient came, and I'll scream, "Hi, Joyce." Joyce knows who she is. Her wrists and ankles are all fused. With a couple of years of Remicade and methotrexate, although her x-rays still look poor, she functions like a normal individual, and nobody would ever know she had rheumatoid arthritis. And for the record, it's very offensive when your family doctor says you don't need these medicines because you don't have rheumatoid arthritis, merely because you're being treated correct, and the doctor didn't know what you looked like prior and doesn't understand that without the drugs you'll be dysfunctional all over again. The long-term outlook in rheumatoid arthritis these days is amazing. We have many choices of drugs. We have many different categories of drugs, whether it's interleukins or whether it's TNF or whether it's doing both at the same time with what would be called JAK-STAT inhibitors. Janus kinase and STAT has something to do with turning on the system and having the enzymes move around. I can't think of exactly what the acronym stands for. Really not that important at the moment. So, with proper assessment, diagnosis, and treatment, your rheumatoid arthritis patients 99% of the time should do very well. Now, what does it mean that we have multiple drugs and we have so many drugs and everybody wants to try everything? Well, if one drug was perfect, we would never need a second choice. So there's no drug that's perfect for everyone. We have to think about why we choose based on comorbidities, meaning other illnesses, and other medications the patients take. So having choices is a good thing in an imperfect world. Having different categories to choose from is also a good thing. You're not going to give somebody who has diverticulitis interleukin-6 inhibitor because that's one of its side effects, and so on. Some of the drugs overlap and they can help arthritis of other diseases, whether it's rheumatoid arthritis or lupus arthritis or psoriasis-related or sarcoid-related arthritis or ankylosing spondylitis. And on a final note, you don't want to be on one drug. You need a combination of methotrexate and all DMARDs. Combination of methotrexate, which is a DMARD, and all biologics works better than any biologic or methotrexate by itself. If I missed anything, I apologize, but you got a good 16 minutes out of me, and hopefully this covers all levels of rheumatology knowledge that can reach out to patients, students, residents, fellows, and co-physicians. Thank you.